Dr. J.V. Peter is the current Director of CMC Vellore and Professor of Critical Care Medicine, Division of Critical Care. He is the President, Indian Association of Respiratory Care since October 2018. He has trained in internal medicine and critical care at the Queen Elizabeth Hospital and Lowell McEwen Health Services, Westmead Hospital, Sydney, and Wesley Hospital, Brisbane, and Lowell McEwen Health Services, South Australia. He has received the Presidential Citation, Indian Society of Critical Care Medicine 2017. He was editor, Critical Care Update from 2006 to 2010 and is currently the editorial board member, Indian Journal of Critical Care Medicine, and section editor for Critical Care, Pathways in Emergency Medicine journals. He has also been invited to speak at various national and international conferences and has more than 120 publications in various indexed national and international journals. Sir will speak to us today on managing effects of prolonged ICU stay.
Thank you for the opportunity to make this presentation. I have modified the talk slightly to say what are the effects of prolonged ventilation. For this talk, I'll start with a brief introduction and go through some definitions. What are the factors associated with prolonged ICU stay and ventilation? What are the strategies that we can use for successful weaning? And then outcomes and some concluding remarks. I want to start with a small anecdote that I came across when I was doing my training in intensive care. It was told that Mr. John Smith died and reached heaven. And he was met at the pearly gates by St. Peter, who asked him, "Why are you here?" So he said, "I have lived a very good life and I'm supposed to reach heaven and I've come." So St. Peter looked at his list for the day and said, "No, I don't find your name here. You must have come to the wrong place. Why don't you go to hell?" So this guy goes down to hell and meets Mr. Satan, and Mr. Satan said, "No, you're not destined to be here." So he goes back to heaven, and suddenly St. Peter asks him, "Can you tell me a little more about yourself?" And when he stated a few things, St. Peter said, "Oh, you were that person who was supposed to come to heaven 3 weeks back. Why were you late?" So he said, "Those guys in the ICU didn't let me go and kept me there for 3 extra weeks." Now, why I'm saying this is that there is a lot of humor and jokes made on intensivists and about prolonged ventilation. But when it comes to your own patient, you would like to do everything possible. Now, critical care provides continuous monitoring and organ support in the acute phase of illness. And we know that over time, there has been improved outcomes due to a better understanding and the ability to provide advanced life support. Significant improvements in mortality has been seen over time. And this is a report from US where they've shown a reduction in mortality over time. And even if we look at our own medical intensive care, where we manage about 85% of the patients are ventilated, there is a reduction in mortality from 40% to 23%. Now, in a proportion of patients, recovery is not possible and they become dependent on life-sustaining treatments. And this subset of patients are called chronic critical illness. And since mechanical ventilation is the cornerstone for critical care, prolonged ventilatory dependence becomes literally the proxy for chronic critical illness. Now, there is a consensus definition that has been developed for this term chronic critical illness, and there are 6 eligible conditions for this. The first is prolonged mechanical ventilation, which is the focus of this talk. Tracheostomy, stroke, traumatic brain injury, sepsis, and severe wounds, and the duration should be at least 8 days. Now, when we look at the term prolonged mechanical ventilation, there are 3 definitions. The first is the National Association for Medical Direction of Respiratory Care that defines a prolonged mechanical ventilation as the need for more than 21 consecutive days of mechanical ventilation for more than 6 hours a day, and this is the most widely used definition. The European Respiratory Society Task Force also talks about the need for more than 7 days of weaning after the first spontaneous breathing trial. The WIND definition, the weaning according to new definition, says prolonged weaning is defined as successful extubation after more than 3 spontaneous breathing trials or taking more than 7 days. Now, the next two aspects are whether the chicken came first or the egg came first. Uh, the thing is, what are the factors associated with prolonged ICU stay and what are the effects of prolonged ICU stay are something as to which came first. Now, prolonged ICU stay may be a result of premorbid chronic conditions, persistent sepsis, severe illness, abnormal cardiovascular function, critical illness, neuropathy or myopathy, and several respiratory factors may also contribute to prolonged ICU stay. Patients staying in ICU may develop complications, which makes them stay longer. They can be sleep deprived, they can have ICU associated delirium, and there may be problems also with the way ICUs are run, and all these may contribute to prolonged ICU stay. Now, what are the effects of prolonged ICU stay? Now, nosocomial infections can be the cause of prolonged ICU stay, but prolonged ICU stay by itself can also cause nosocomial infections. And how do we approach this? By use of appropriate antibiotics, hand washing, appropriate line change, subglottic sectioning. Now, it is said that in an ICU setting, the risk of nosocomial infections is about 2% per day and reduces to about 1% per day after the first week. Pressure sores are also an effect of prolonged ICU stay, and this can be avoided by frequent position changes and the use of alpha mattress. Vascular events is the other thing that can happen in prolonged ICU stay. Myocardial infarctions, pulmonary embolism, cerebrovascular accidents. Of these, only PE is significant, and this can be reduced or prevented by DVT prophylaxis. Gastrointestinal bleeding can be prevented by stress ulcer prophylaxis. And there are two major components of the prolonged ICU stay, which is ICU psychosis and delirium, and muscle weakness and ventilator dependency, which we'll talk about in a bit more in detail. But before going on to that, this is one study that has looked at the consequences of prolonged ICU stay and what are the ones which are significant, and in amongst these, pulmonary embolism, muscle weakness, ARDS, nosocomial sepsis, GI bleeding, pressure ulcer and delirium come as risk factors as the ones which are strongly associated with prolonged ICU stay. Now, in terms of delirium, how can we prevent and treat? There are non-pharmacological measures. There are several measures that are put in this slide, like treating pain appropriately, using benzos appropriately, monitoring patients for delirium, and providing optimal stimulus and early mobilization. But there are several non-pharmacological measures that are also used both for the prevention and treatment of delirium. And delirium, as I said earlier, can prolong ICU stay, and this needs to be looked for and treated appropriately. What is the magnitude of this problem of prolonged mechanical ventilation? There are two studies, one from Brazil and one from Canada. The one from Brazil is a smaller study of 5,287 patients, of which 9.9% required ventilation for beyond 21 days. The Canadian study is a much larger study. Both these are retrospective studies, which the Canadian study involved over 2 lakh patients, and the proportion of patients who stayed in ICU beyond 21 days was 5.4%. Now, when we look at prolonged ICU stay, as I said earlier, one of the factors that result in prolonged ICU stay is prolonged ventilation. And so we will focus a lot on ventilation and how weaning happens. Now, in a normal individual who's in the acute phase of illness, who needs ventilatory support, the idea is to try and gradually reduce ventilatory support and try and extubate them. Now, in a proportion of patients, this may not be possible, and then you can go through a series of steps by which you try and get them off the ventilator. And the series of steps include tracheostomy, speaking valve, overnight wean, and decannulation, and we'll look at this briefly. Now, when we look at reduction of pressure support, we start reducing the pressure support gradually. This is a patient who's on a spontaneous mode of ventilation, but each breath is pressure supported. We keep coming down, titrating down, not only on the pressure support, but also on the PEEP and the FiO2, and we establish thresholds at which we try and get them off the ventilator. And the standard threshold we say is pressure support of 7 and PEEP of 5. Here it says 8 and 5, but 7 and 5 is what we use in CMC, and a FiO2 of at least 35 to 40%. Now, those who are not on a tracheostomy will obviously be extubated, but those who are on a tracheostomy will go on to a tracheostomy trial, which is this slide that I put up, where you take the patient off the ventilator and give them short trials on a tracheal mask and gradually increment this over a period of time till the person is able to be sustained in his ventilation without any respiratory support. Now, once a person is able to tolerate tracheal mask trial increments, then you assess cuff leak. A lot of patients, you'll find that once you let down the cuff in patients who have prolonged mechanical ventilation, they're not able to clear the secretions, and they start coughing, do not tolerate the cuff leak or the cuff down as we call it, and may also go backwards in terms of the respiration. So if they pass the cuff leak test, then you change the tracheostomy tube to a speaking valve. Now, once this is done, we still would need to wean this person off ventilation completely. And that's when you give them weaning during the day, put them back on the ventilator overnight, and gradually reduce the time that they spent on the ventilator overnight, and then you get them off the ventilator, and once they're off the ventilator, you decannulate. The corking that is advocated in this guideline from Canada is not done at this point of time, but once they're completely off the ventilator, you decannulate the patient. Now, what are the strategies for successful weaning? Now, there are 4 different aspects that I would like to look at. First is the ventilatory strategies. Second is weaning protocols. Third is early mobilization and physiotherapy. And fourthly, specialized weaning units. Now, when we look at ventilatory strategies, we can look at 3 different dimensions of ventilatory strategies. First is, what is the mode of ventilation that you use to wean them off a whole lot of respiratory support? Second is, what is the ventilation type, whether you use non-invasive ventilation or invasive ventilation? And finally, just before you get them off the ventilator, do you use pressure support weaning or a spontaneous breathing trial? Now, one of the things that became very popular about 15 years ago was the use of a neurally assisted ventilation, where normally the trigger for ventilation for a patient is a change in flow or pressure. Now, as a patient takes a breath, the ventilator circuit senses a change in flow or a change in pressure. And when this happens, the inspiratory valve opens and air is pushed into the lung, or air is sucked into the lung depending on the type of ventilation. Now, because there is a lag, there can be a bit of dysynchrony. And this tool tries to avoid this lag by having an electrical trigger rather than a pneumatic trigger. And what it does, it senses when the diaphragm is excited, and hence is able to coordinate with the ventilator much better. Now, there are very limited studies. There's one study which has compared NAVA with pressure support weaning in 13 tracheostomized patients, and they looked at 4 different levels of assistance, and they found that increasing level of assistance increased tidal volume in pressure support ventilation, but not in NAVA. But the advantage of this was that NAVA would reduce over distension. They also found that the tidal volume variation was higher in NAVA than in pressure support ventilation, and ineffective trigger was similar in 2 groups. So this didn't really show any convincing benefit of NAVA over pressure support ventilation. But there is another larger meta-analysis that looked at 15 studies which compared 3 different modes of ventilation: NAVA, pressure support ventilation, and proportional assist ventilation. Now, what do you mean by proportional assist ventilation? The ventilator sort of gauges the elastance and resistance of the lung and adjusts the amount of pressure support that it will give for each breath. For example, if you need 15 centimeters of pressure to generate a volume and the patient contributes 10, the ventilator will give 5. If for the next breath the patient is able to generate only 7, the ventilator will give 8. So that is what PAV broadly means. Now, what they found was they looked at something called a reduction in asynchrony index of more than 10%, and they found that it was significant for proportional assist ventilation, where there was much better synchrony. And when they compared NAVA with pressure support ventilation, NAVA scored over pressure support ventilation. Now, there was a reduction in duration of ventilation with proportional assist ventilation, but not with NAVA. Going on to the ventilator strategy type, whether it should be invasive or non-invasive ventilation, this study looked at 231 patients with chronic critical care, and 85.7% were weaned after about 3 weeks, of which 21% needed NIV during ventilation weaning. And they found that the arterial CO2 at admission predicted the need for non-invasive ventilation. Now, non-invasive ventilation can be used as a bridge therapy between invasive ventilation to liberation from the ventilator. So that brings me to the third dimension, which is how do you actually liberate somebody from the ventilator? Do you use pressure support or do you use spontaneous breathing trials? And this is a meta-analysis of 10 studies that have compared these two, and they found that there was no significant difference whether you use pressure support as a weaning and liberating tool or spontaneous breathing trials. The second dimension is whether a protocolized form of weaning as opposed to non-protocolized form of weaning would hasten extubation and liberation from ventilation. There is a Cochrane systematic review which has looked at it in patients who are not on prolonged mechanical ventilation. And what they found was that protocolized weaning was able to reduce mechanical ventilation duration by 20 hours, ICU length of stay by 9 hours, but there was no difference in hospital length of stay. Now, these are, if you look at the slide, these are very highly statistically significant differences when you use a protocolized weaning. But if you look at the actual duration that you save using a protocolized weaning, it's 20 hours and 9 hours, which are not clinically significant. So the take-home message is if somebody is ready to come off the ventilator, they will come off the ventilator irrespective of whether you use a protocolized weaning or a non-protocolized weaning. But, and this is the summary of the Cochrane meta-analysis. There is only one study which has looked at protocolized weaning for patients who have been on prolonged mechanical ventilation, and this is a study on COPD patients, which is a retrospective study which is compared with a prospective study where patients were requiring mechanical ventilation for over 15 days. Now, this study showed that a protocolized weaning was significantly better, not only statistically significantly better, but clinically significantly better in terms of getting them off the ventilator. The only problem is that it's a small study and it's retrospective and it's for a very select subgroup of patients, so generalizability becomes a problem. Now we move on to the next dimension of the consequence of prolonged mechanical ventilation and how we avoid that, which is severe muscle weakness and deconditioning. A significant proportion of patients who are on prolonged mechanical ventilation develop persistent muscle weakness, and there is muscle deconditioning and atrophy, and ICU acquired weakness contributes to morbidity as well as mortality. Now, can we reduce this by early mobilization and physiotherapy? So first thing is to ask whether early mobilization and physiotherapy whilst on a ventilator, whilst in the ICU is safe. And this is a meta-analysis that has looked at a huge number of patients, and it looks like it's relatively safe because the number of adverse events due to mobilization is extremely small, in most cases less than 1%. The second is the timing. Do you start it when they are acutely ill or when they have just recovered from ICU so that you can hasten the transition from hospital to home? Now, if you again, this is a meta-analysis, not very large number of patients, and this suggests that if you do aggressive physiotherapy whilst they're in ICU, whilst they're in the ventilator, it can improve weakness and maybe hasten recovery and discharge. However, when you look at it in the long term, its effects are not very sustained. There are also studies which have looked at post-discharge rehabilitation in mechanically ventilated patients, again, the evidence is not strong. In fact, the numbers are very small and there is wide confidence interval, and hence we are not able to say whether this aggressive physiotherapy and rehabilitation will benefit in terms of reducing prolonged mechanical ventilation. Now, there are lots of things that we anyhow need to do. We need to clear secretions, we need to keep the muscles stretched and active, and so there is a role for some of these to happen on a regular basis in the intensive care. Whether or not it makes a difference to the outcome is secondary, but these need to be done. Is there a specific role for specialized weaning units? Let's say somebody is requiring prolonged ventilation. Do you waste the resource of an acute care unit and say, okay, this person can be moved to a chronic care unit? There are different terminologies that are used. Does it really help? Now, I'll address this while we come to the outcomes of patients who are chronically critically ill. We have outcomes at 1 year as well as beyond 1 year. And this is a large meta-analysis which was published in Lancet Respiratory Medicine involving over 60 studies. When we look at mortality at hospital discharge for acute care, about one-third, less than one-third, about 30% of the patients pass away due to an acute illness requiring ICU care. But when you look at mortality at 1 year, we find that this nearly doubles to close to 60%. And irrespective of where they are treated, it doesn't seem to make a difference, except for those treated in specialized weaning units, where the mortality at 1 year seems to be a little lower. But if you look at mortality beyond 1 year, about 2/3 of these patients actually pass away. So those chronic critical care, 2/3 of the patients die after 1 year. Now, if you look at those who have been off the ventilator, again, if you look at it, pooled data, about 50% of them are able to get off the ventilator over the period of 1 year, which is not too bad. 50% survival, being liberated from the ventilator seems to be reasonable. But what is worrying is this information that about 67% of these patients required readmissions. And at the end of 1 year, only 9% were alive with functional independence and 26% were alive with moderate dependency. So if you look at club these two, about 1/3 of the patients have a relatively okay outcome in those who are have prolonged mechanical ventilation. Now, this comes with a tremendous cost, not only costs in terms of money spent, but it needs a lot of family support, nutritional support, issues of managing tracheostomy and decannulation. And in those who have medical futility, the whole issues of end-of-life care, whether we withdraw or withhold, all these things also need to be addressed. So to conclude, critical care outcomes have improved over time. Chronic critical care is an evolving field, and definitely with better understanding of how to manage these patients, survival is a lot better than what it used to be in the past. About 50% survive at 1 year. But this survival comes at a huge cost, with functional independence of only less than 10% at the end of 1 year. And it also comes with a lot of ethical issues on how to make these decisions on prolonged ventilation, when to make the decisions, and this is something that needs a lot of care and attention. Thank you for this opportunity to make this presentation.